Welcome back to embryology sessions. Today's topic is on development of face, tongue, thyroid gland and palate. Here is the embryology chart which explains the development of face. So the face develops mainly from 5 processes. The 5 processes are frontonasal process, 2 maxillary process and 2 mandibular arches. So altogether 5 processes contributes in the development of face. So if you see the frontonasal process, it again grows as median frontonasal process, which grows into the median part of the nose as well as the upper lip, the central part of the upper lip, which is called as philtrum. And lateral nasal process or lateral frontonasal process, which contributes in the formation of lateral wall of the nose. And the red colored structure are derived from the maxillary process, which forms the rest of the upper jaw as well as the cheeks below the eyes. We can also see the lens placodes or optic placodes, which are present above the maxillary process and below the frontal process. So these lens placodes are derived from the ectoderm. So they are ectodermal thickenings which grow as lens. And we can see the optic placodes which appear laterally, which forms the part of ear. And nasal placodes or olfactory placodes which appear here on each side of the median nasal process and which grows later to form the nasal cavity. And here the future mouth is called as stomatodium. So here is the stomatodium. So stomatodium forms the future mouth, which is covered by the buccopharyngeal membrane. Later the buccopharyngeal membrane ruptures to form the stomatodium. So let us discuss on the development of face little more in detail. So as I said earlier, development of face, the face develops from 5 processes: 1 frontonasal process, 2 maxillary process, 2 mandibular arches. Frontonasal process divides into median nasal process and 2 lateral nasal processes which are present on the either side. Nasal placodes, the elevations which are formed by the proliferation of ectoderm overlying the head mesoderm between the median nasal process and lateral nasal process are nasal placodes. Later these placodes deepens to form nasal pits. So the nasal pits are the depressions in the nasal placodes and each extends backwards. These nasal pits invaginates backwards to form nasal canals, and later they divide the median nasal processes into median and lateral nasal process. So because of these nasal canals, we divide the median frontonasal process and lateral frontonasal process by the groove, and further it deepens to form the nasal cavity. So if we see the development of nose develops, that is the lateral wall of the nose is derived from the lateral nasal process. Nasal septum, that is the center part of the nose, that is the median part of the nose, is derived from median nasal process, and structures developed from the median nasal process are nasal septum and philtrum, which is the center part of the upper lip, and that is called as the philtrum, and premaxilla which folds the front 4 incisors. The part of maxilla with 4 incisors are derived from the premaxilla, which is also derived from the median frontonasal process. And let's see about the development of face further with the maxillary. So the maxillary process fuses with the lateral nasal process to form nasolabial fold, and lateral nasal process fuses with the median nasal process to form openings of the nasal cavity called as anterior nasal apertures or anterior nares. And the 2 maxillary process fuse across the midline to form the upper lip and the jaw. So suppose if the maxillary process fails to fuse with the lateral nasal process where it forms the nasolabial fold normally, if this fold fails to form, it results in a fissure which is called as oblique facial cleft. The two mandibular arches they fuse across in the midline to form the lower jaw and lower lip as well. So maxillary and mandibular process of each side fuse with each other to form cheeks. So as a result, the primitive oral cavity, which is the stomatodium, it reduces in its size because of the fusion of maxillary and mandibular process. So it confines the opening of the oral cavity to the anterior side. So it reduces because of the fusion of maxillary and mandibular process on each side. So let's see the congenital anomalies of face, that is the cleft lip. Cleft lip, it is, we know the median frontonasal process fuses on each side with the maxillary process here. So suppose if it fails to fuse to form the upper lip, it results in the cleft lip. So if it is on one side, it is called unilateral cleft lip, and if it is on both the sides, it is called bilateral cleft lip. And this cleft lip sometimes can be associated with the cleft palate. So if we see inside, the palate is also not fused, and we would discuss about the palate little later along with the development of palate. Cleft lower lip or cleft lower jaw means the two mandibular arches, if they fail to fuse in the midline, it results in a cleft lower lip or cleft lower jaw. Next, about the oblique facial cleft. Oblique facial cleft, we know the maxilla is here, the pink color structure, and the blue is the lateral nasal process. So if lateral nasal process and maxilla, they fuse on either side to form nasolabial fold. Suppose if they fail to fuse, it results in oblique facial cleft where the nasolacrimal duct is exposed out. Nasolacrimal duct extends from the medial side of the eye into the lower part of the nasal cavity. So this duct exposes out if there is oblique facial cleft. Next condition which is associated with the development of face is cyclops with proboscis. It is a congenital anomaly where it is identified by a nose-like projection over the forehead, and instead of having two eyes, the baby may have a single eye in the center. And cyclops with proboscis, usually the babies are stillborn. First arch syndrome, which is otherwise called Treacher's-Collins syndrome, all the first arch derivatives fails to the development in first arch syndrome. Okay, so these are the congenital anomalies, that is the cleft lip, cleft palate and cleft lip together, and the cleft lip and the jaw, lower jaw, and oblique facial cleft, cyclops with proboscis, and first arch syndrome, which is otherwise called as Treacher's-Collins syndrome. So that was about the development of face. The next embryology chart shows the development of the tongue, where it develops in the floor of pharyngeal arches. So if you see in the floor of pharyngeal arch, the red colored structure is the floor of first pharyngeal, blue is the floor of second pharyngeal arch, yellow represents the floor of third pharyngeal arch, and green one the floor of fourth as well as the sixth pharyngeal arches. So the tongue usually develops from the floor of first pharyngeal and the floor of third pharyngeal. We can see here in the floor of first pharyngeal, there are two swellings which are present on either side on the red color, which are called as lingual swellings. And just behind the lingual swellings, there is a median diamond-shaped elevation which is called as tuberculum impar. So the lingual swellings and tuberculum impar, they all joins to form anterior 2/3 of the tongue. So anterior 2/3, the mucosa is derived from the endodermal lining of lingual swellings and tuberculum impar. And the second pharyngeal arch when you see from second picture, there is no blue color because the second pharyngeal arch, the floor of second pharyngeal arch doesn't give rise to the development of tongue at all. So talking about the third pharyngeal arch, you can see an oval elevation which is present in the third pharyngeal arch, which is called as hypobronchial eminence. So this is called as hypobronchial eminence, which is further divided into cranial part and caudal part. So cranial part of hypobronchial eminence, this is the caudal part of hypobronchial eminence. So both cranial and caudal part. The cranial part gives rise to, means that yellow colored one, which is the floor of the third arch, gives rise to posterior 1/3 of the tongue. Whereas the caudal part of hypobronchial eminence, you can see most posterior part of the tongue which connects to the epiglottis. So here we can see the development of epiglottis also. So that is about the most posterior part of the tongue. And the gap here, which is the posterior side, this one is the laryngotracheal groove. Laryngotracheal groove deepens to form the respiratory tract. And we can see on each side of the developing tongue the pharyngeal arches. So first, second, third, fourth and fifth disappears and sixth is here. So they are the pharyngeal arches which is present on each side of the developing tongue. So we can discuss the development of tongue is epithelium, muscles, connective tissue. So the epithelium of the tongue is derived from the endodermal lining of the pharyngeal arches, means the floor of the pharyngeal arches is covered by a layer of endoderm. So the lingual swellings, tuberculum impar and hypobronchial eminence are formed because of the endodermal lining which forms the epithelium. And muscles of the tongue, that is skeletal muscles of the tongue, they are all derived from the occipital myotomes. So if you remember the somite is derived into sclerotome, dermatome, myotome, and 4 to 5 occipital myotomes gives rise to the skeletal muscles of the tongue, which forms the major substance of the tongue. And as we know, the occipital myotomes develops posterior to the head. They are dragged laterally into the developing tongue. So that is the reason the hypoglossal nerve, if we see, it courses from posterior to anterior, crossing both internal and external carotid artery. So hypoglossal nerve lies superficial to internal and external carotid artery, and its course is from posterior to anterior because the occipital myotomes, they develop initially posterior part of the head and they are dragged towards the developing tongue during the development. Connective tissue of the tongue, it is derived from the surrounding mesoderm. Surrounding mesoderm or mesenchyme gives rise to connective tissue of the tongue. So if you see, epithelium, anterior 2/3 are derived from the two lingual swellings and tuberculum impar. All three are derived from the floor of first pharyngeal arch, that is the mandibular arch. Posterior 1/3 including circumvallate papillae. So the cranial part of hypobronchial eminence are derived from the third arch. And most posterior part, that is the caudal part of hypobronchial eminence, which gives rise to the most posterior part of the tongue, which is from the floor of fourth arch. So that is the reason if we see the sensations, anterior 2/3 general sensations, it is supplied by the lingual nerve, and for the taste, that is the special sensation for anterior 2/3, it is supplied by the cauda tympani nerve. Cauda tympani nerve is the pretraumatic nerve of first pharyngeal arch. And the second arch, that is the second arch, doesn't give rise to the tongue at all. The third arch gives rise to posterior 1/3 of the tongue. So the nerve of the third arch is the glossopharyngeal nerve. That is the reason the glossopharyngeal nerve supplies both general sensation as well as special sensation, that is to circumvallate papillae. Circumvallate papillae, they lie in the anterior 2/3 of the tongue, but developmentally they are from the posterior 1/3 of the tongue, and they migrate to anterior 2/3 in front of sulcus terminalis later. That is the reason circumvallate papillae are supplied by glossopharyngeal nerve. Posterior most part, we know it is derived from the fourth arch. So the nerve of the fourth arch is the vagus. So posterior most part, it is supplied by vagus. So as a summary, the muscles of the tongue are derived from occipital myotomes except palatoglossus. Palatoglossus is derived from the fourth pharyngeal arch. And connective tissue surrounding mesoderm gives rise to the connective tissue of the tongue, and epithelium is from the endoderm lining all first, third and fourth pharyngeal arches. Congenital anomalies of the tongue. If tongue doesn't develop at all, absence of tongue is called as aglossia, and partially developed tongue is termed as hemiglossia. And tongue tie. Tongue tie is the lower part of the tongue. Inferiorly, the tongue connects to the floor of oral cavity by means of frenulum linguae. So this frenulum linguae, it is attached excessively to the floor of oral cavity, then it results in ankyloglossia or tongue tie. Lingual thyroid. So we know the anterior 2/3 of the tongue is from first pharyngeal arch, posterior 1/3 is from the third pharyngeal arch. The second pharyngeal arch, the floor of second pharyngeal arch grows down to form the thyroid gland. Suppose if it fails to form, the thyroid descends down into the thyroid level and it develops within the tongue, forming a swelling inside the tongue called as lingual thyroid. Bifid tongue means the both right and left lingual swellings, if they fail to fuse, results in two separate halves of the tongue called as bifid tongue. So these are some of the congenital anomalies associated with the development of tongue. The next embryology chart what you are seeing is development of thyroid gland. So development of the thyroid, as we discussed just little before, that the tongue develops from the floor of first arch and floor of third arch and floor of fourth arch. The second arch doesn't form the tongue at all. So the junction between the first and the third arch, there is a foramen here which separates along with the sulcus terminalis. So this foramen is called as foramen cecum. Cecum means blind. In adults it is a blind foramen, so it is called foramen cecum. But during development, this foramen cecum grows down, forming a diverticulum at its lower end, which is called as median endodermal thyroid diverticulum. And the tube which connects the foramen cecum to the thyroid diverticulum is called as thyroglossal duct. Thyroglossal duct, in the sense it is connecting, glossa means the tongue, thyro means the thyroid gland, so it is called the thyroglossal duct, and which is a temporary structure which later completely disappears, forming a fibrous tissue in adults. Suppose if the thyroglossal duct fails to obliterate completely, it may result in fistula, that is called as thyroglossal fistula, where one side of the thyroglossal duct is open, or the center part of the thyroglossal duct is patent, which is filled like a cyst, and rest of the thyroglossal duct is obliterated. Then in that context it is called as thyroglossal cyst. And not complete the thyroid gland is derived from this endodermal diverticulum. Even the parafollicular cells of the thyroid gland, they are derived from the endodermal pouches, to be specific from the caudal part, which is called as caudal pharyngeal complex. So caudal pharyngeal complex and our ultimobranchial body gives rise to parafollicular cells of the thyroid gland, and rest of the thyroid is derived from the median endodermal diverticulum. Connective tissue of the thyroid is derived from the surrounding mesoderm and mesenchyme. Let's talk about some congenital anomalies of thyroid. The first anomaly is the lingual thyroid, where the thyroid gland the thyroglossal duct fails to grow down, forming a thyroid diverticulum at its lower end. Instead, the thyroid gland develops within the tongue itself, within the substance of the tongue. Then it is called as lingual thyroid. Next condition, suprahyoid thyroid. So here we can see this is epiglottis, and we can see other cartilages of larynx, thyroid cartilage, and here is the hyoid bone, and we can see the cut section of cricoid cartilage. So as we see here, the course of thyroglossal duct, it runs in front of the hyoid and descends below the hyoid and reaches below the thyroid and reaches till the tracheal rings. So that is how it reaches to the adult level. So if the thyroid gland forms above the hyoid bone itself, then it is called suprahyoid thyroid. And if the thyroid diverticulum forms behind the hyoid, then it is called retrohyoid thyroid. And instead of settling below the thyroid cartilage, if the thyroid diverticulum develops at the level of thyroid just below the hyoid, then it is called infrahyoid thyroid. And suppose the thyroid gland forms somewhere else, especially in the posterior triangle of the neck, then it is called ectopic thyroid. So these are the few congenital anomalies associated with the development of thyroid gland. The next embryology chart is the development of palate. So the palate has got the hard palate and posterior part forms the soft palate. And if we see the palate, it develops as two forms, that is primitive palate and definitive palate. Here we can see two images showing premaxilla, which is the primitive palate, and lower image is the definitive palate. So here in the primitive palate, we can see the yellow one is the median nasal process. So the median nasal process, just before we saw the development of face, that median nasal process forms the nasal septum and philtrum, that is the center part of the upper lip, as well as the premaxilla, which folds the four incisors. So the premaxilla is derived from the median nasal process. So initially the premaxilla alone forms the palate. On each side of the premaxilla, we can see the developing maxillary process. So the maxillary process forms a shelf-like process which is called as palatine shelves. So palatine process of maxilla, from right and left they approximate with each other and joins with the premaxilla to form a definitive palate. So we can see in the second image the definitive palate is formed. So here the palate has two sources of origin. Premaxilla is from the median nasal process and palatine shelves of maxilla forms the rest of the palate. And anterior 2/3 of the palate, it gets ossified to form a hard palate, whereas the posterior 1/3 remains unossified, forming soft palate containing muscles in it. And let's talk about some congenital anomalies associated with the development of palate, that is unilateral complete cleft palate. Means here is the premaxilla and posteriorly it continues with the between two maxilla. So this is one side. If fails to fuse, it is called as unilateral cleft palate. This is a unilateral cleft palate, and usually palatine process it starts fusing from anterior to posterior. So the anterior, sometimes few kids they may be normal, but when we observe inside, the two palatine process of maxilla may fail to fuse. That is called as partial cleft palate. In complete unilateral cleft palate, what happens? One side of the premaxilla fails to fuse with the one side of the palatine process of maxilla. Bilateral cleft palate means both the sides if fails to fuse, it is called as bilateral cleft palate. So this is bilateral cleft palate where both the sides the premaxilla fails to fuse with the palatine process of maxilla. Bifid uvula means whole palate is fused except the posterior part of the palate fails to fuse here. So where the uvula, which is the overhanging part of the soft palate, it appears to be bifid. That is called as bifid uvula. So these are the few congenital anomalies which are associated with the development of palate. So that is regarding today's embryology charts, and in further sessions we would like to know some more embryology charts. Thank you. Take care.